Hi, everyone. This is Lucas Voss with Becker's Healthcare. Thanks so much for joining us for today's webinar, The Future of Risk Adjustment Moving Beyond Chart Chase. Before we begin, I'll walk us just through a few quick housekeeping instructions here. If you have any questions for our speakers throughout the webinar, please feel free to type them into the Q&A box you see on your screen. We can follow up to get you an answer there. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that same recording. And if at any time you have any issues with audio or visuals, just try refreshing your browser. You can also submit any technical questions into that Q&A box you see on your screen. We're certainly here to help you. And with that, I'm so excited to welcome such a wonderful panel for today's discussion. We certainly have a lot to discuss. Before we do that, though, I do want to start us off with introductions for those that might not know you yet, at least. And I also have a hard introductory question. Just kidding, it won't be that hard. Can you, again, introduce yourselves? Lisa, I'll start off with you. Can you talk a little bit about your role and organization? And here comes the hard part. One word that captures how health plans are approaching risk adjustment today.
Okay, so I'm Lisa Purnell. I'm the Director of Risk Adjustment at Community Health Choice. And one word that I would describe risk adjustment today, for us being a regional plan, I would say exposed.
That's a good one. I like that one. Yeah, absolutely. Mark, over to you.
Morning. Hi, I'm Mark Dabney. I'm Director of Risk Adjustment for the Community Health Plan of Washington. We're a regional not-for-profit covering Medicare, Medicaid, and ACA. For me, the one word for risk adjustment is cautious.
Dr. Masudi, over to you.
I'm John Masudi. I'm the Chief Medical Officer of Clear Spring Healthcare. I spent a lot of time in my career as a clinician, as a urologist, and a leader with the Permanente Medical Group, where I learned a lot about risk adjustment. And I would say plans are facing risk adjustment carefully.
Carefully. Very good. Yes. Last but certainly not least, John, over to you.
Thank you, Lucas. So thanks for having me. I'm John Murtha. I'm Health Plan Executive at InterSystems. My background is in health plan operations, strategy, and clinical data interoperability. The one word that I would say, and it's already been said by Lisa, would be exposed.
Let's keep those words in mind because I think we'll come back to them here in our discussion later on. I think they capture where we're at today very nicely. And I do want to talk a little bit about the approach that we have been seeing historically. Again, we talk about chart chasing and retrospective review so much, and they've been that backbone of risk adjustment, certainly. What are, from your perspective, the real operational, financial, and clinical costs of staying on that path and using that retrospective review and that chart chasing piece as the approach for now? Lisa, I'll start off with you. I'll still muted there, Lisa.
Sorry about that. I like to do that all the time.
No worries.
Retrospective review is the most expensive way to fix yesterday's problems. It drains operations, it destabilizes revenue, and it does nothing for the member in front of them. If we're still chart chasing, in 2027, we're investing in the past instead of point of care.
Yeah, absolutely. Mark, I'm assuming this is similar for you as well when we're looking at that retrospective process in and of itself. What does this look like for you? And is it, if we're staying on this path for 2026, 2027, what does that mean beyond that?
Yeah, you're right. It looks pretty similar to, Lisa, what you had said. For us, some of the constraints that we find is you're doing this well after the year. Your financials are hinging on something that's happening well after that point of care. And the immediacy of communication to the providers that are doing the care, they're finding out, ooh, you missed something or you miscoded something months or maybe a year later. So how do you have a good, collaborative interaction with your providers so they know what they could be doing upfront versus what we're figuring out at the end? And then, of course, trying to track the financials of, well, we expect to get this in a year. and we'll see if we actually hit that target through what's in the charts or what's happening up front.
Yeah. Dr. Masudi, again, your clinical background certainly brings a different perspective to this as well. But again, looking at this process in and of itself and the cost from a clinical perspective, but also operationally, what
Mhm.
is it if we stay on this path?
Well, it's just going to be more of the same. It's like having a grocery store where you allow people to just have an IOU to pay for the groceries, and then you have to go back and get them. So you need to have something that works at the point of care when the encounter is closed or before the encounter is closed, or you're just going to keep doing the same. And the other thing is with chart chase, you're going to also find stuff that was coded that shouldn't have been. So it's not always necessarily going to lead to more revenue per se.
John, I'd love to lean on your industry overview, so to speak, your industry perspective on this too. What
Mm.
are you seeing nationwide? And again, just listening to our panelists here, is that something that you're seeing organizations react to? Are they realizing that there is this impact? What does this look like from where you're sitting?
Yeah,
Yeah.
I mean, I
Oh, I'm
think
sorry.
you said John, right?
Yeah, John,
Yeah,
go
oh,
ahead.
sorry, Mark.
No
No,
problem.
I mean, I do love hearing from Lisa, Mark, and Jonathan. They're on the front lines. They're dealing with this. And, Lucas, I think everyone is faced with this challenge of how do we make this pivot? Because this world that we're sort of pivoting from, I think, we all were, this whole process was set up to, you were supposed to retrospectively validate a few codes here and there and try and complete this picture. Um, and it was fine to set up that process in a world where it was a certain percentage of codes. We're going back to look, we're trying to revalidate something, but now we're actually trying to reconstruct something happening. And when you think about the changes that have happened with moving from version 24 to version 28 with RADV and the amount of scrutiny that's happening with RADV as well. I mean, it's I think the last 6 years of payment are being audited in the next 13 months. That's a massive amount of, audit. We're not talking about, oh, we're going to audit 100 cases here and there. This is massive scale of extrapolation. And so going back retrospectively just for a few codes, that isn't the case anymore. We need to rethink this process, and everyone here on the call is trying to keep up with all of what's happening today and how do we make that leap to the future. It's very difficult.
No, you mentioned the sheer volume of it, which is certainly a big part of the conversation. Where do you see today's model then break down most visibly today? When you're looking at all these processes, volume is certainly a big part of it, but where does it break down most visibly?
I think it breaks down around timing. The encounters already happened, the provider already documented, the claims already moved, and at that point, the plan is no longer influencing the system. It's really just trying to reconstruct it. So it becomes extremely difficult in an environment where you have multiple payment years. As I said, you're trying to audit simultaneously unsupported diagnoses potentially, and that can scale through extrapolation. And so, now when we're talking about CMS doing multiple years and the amount of tax that causes on your provider network, when you think about the number of charts you're chasing, and what that does to your relationship with your providers. Hey, last year we asked for 300,000 charts, and this year we're going to ask for 5 times that, and we're going to manually go through charts. It's untenable.
Yeah. Mark, I saw you nodding your head there, specifically on the fact that it is untenable for the future. But again, same question for you. When we're looking at this model in and of itself, the retrospective nature of it, is there a spot that you're seeing this most visibly break down?
Yeah, I mean, to me, the biggest point that's a frustration, right? I'll do these reviews multiple years back, and most of my plan's partners are FQHCs, right? They're not super accustomed to risk adjustment as a concept, and then in turn having this sort of coding scrutiny. So then knocking on their door and going, do you remember that patient you saw in 2019 or 2020? And half of these clinics were like, we barely survived 2020. Now you want me to find a chart? So it is fighting that fight of like, we want to help. We want to, how do we help you get this chart to us? We're trying to get as limited impact as possible to some of these provider groups so that, our footprint of all the plans that are going to ask them to charts is as minimally invasive as possible. But we are trying to think proactively of, well, what did we learn? What can we share with you so that the providers that are on the front line are able to think ahead, and what tools can we put in place so that future us doesn't have to come back with this kind of thing? Because John, to what you had said, CMS has shown they are coming for financial scrutiny. All these audits are payment integrity audits. And with extrapolation, if that's brought back into the fore, it is foundationally financially impactful. So trying to put that context to the provider to some extent as to here's the why, but also knowing, dear goodness, like 6 audits in 13 months after going silent for 4 years is a tough turnaround.
Yeah. Dr. Masudi, really quickly here, are you seeing this improve? And again, when you're looking at this model, same question for you too. Are there specific points that you're looking at from your perspective in terms of that breakdown that's happening?
Yeah, I think that really combining, I think the breakdown is where people think of risk adjustment as a revenue source, strictly speaking. I think that's where it becomes a problem. And connecting, this is what the topic of the call is today, connecting, high quality care with risk adjustment is how to fix that breakdown. The best way to financial profitability is high quality healthcare. And it just so happens that the byproduct of that is accurate risk adjustment.
Yeah. We'll talk about that process here in a little bit too, but I think that that's a very crucial point. Again, you refer to the title of our conversation today, which is why we're bringing it up. Now, when we're looking at fixing this, we've certainly seen organizations do a number of different things. Vendor management, tightening vendor management, stronger vendor management, again, tightening coding workflows, closing those gaps, process improvements, all those things. It's not like it's being not addressed. There are certainly things that are happening to be able to address some of these things. But I'd love to ask you all why these efforts are not necessarily enough anymore, and what's changed in today's environment that makes these sort of gains that, oh, there is progress, just feel like, again, there's less exposure, there's more exposure and less progress, so to speak. Lisa, I'll start off with you.
Say process improvement tweaks and tighter vendor oversight aren't enough anymore. They're just solving for a world problem that doesn't exist. CMS has moved the goalposts. Every gap you close on the back end, it now highlights a failure at the point of care. I think, if we are able to document and capture everything at that point of care, it's going to make it, easier. When you're doing retrospective, it's black and white. It's there or it's not there. When you're doing something more, prospectively or even concurrently, you're right there and you can make the changes, do what you need to, so that way you can protect the revenue, because nobody wants that extrapolation.
Yeah. John, are organizations understanding that this is no longer enough, right? Because we still see a lot of organizations do this a ton, and they're still doing it. From your perspective, again, do they understand that this is not enough?
I think slowly but surely, yes. I mean, you hear Lisa say it, right? And so, I think most organizations are still trying to do incremental changes in a retrospective world. And so you're getting faster signals when you're getting faster signals into a retrospective world, really all you're doing is it's hard to say, as an operator, I feel better because I'm building up my backlog. It doesn't really make any sense. It's when you break out of the retrospective world and do what Lisa's doing and move up towards the prospective, and it becomes difficult because like she said, in the retrospective world, it's easy. It's black and white. Is it there? When you go into the prospective world, and that's not a place where health plans are typically welcome, like, oh, sure, come on in, health plan. We'd love to have you helping us with documentation. That's, a crowded place where clinical activity is happening. And so that's not typically a welcome place. And so having that collaboration with the providers and trying to do so, as Mark is talking about, in a way where it's educational and you have this collaboration, and ultimately resolving into what Jonathan's talking about is excellent care. That is the goal. So everyone here is inching towards it, and I hope that everyone listening is gaining something from this. This is a great panel. Thank you, Lucas.
I'd like to just amplify
Yeah, go ahead.
something that John just said, which is that I think provider-sponsored plans, a provider-sponsored MA plan has a lot more control over the behavior of physicians, and the incentives are aligned. And that's one thing I found at Kaiser Permanente, because the health plan and the medical group are aligned. It's much easier to move people in the right direction.
Yeah. Mark, to the second part. Yeah, go ahead, Lisa.
Just to add on to that, you mentioned provider incentives. I think that is also key in getting this to work. If providers don't have any, skin in the game, they're not going to pay attention to any other education that we go in and do. Why? What does it matter to them? So I think having that provider incentive around, risk adjustment and even quality makes a huge difference, because then, they don't get paid that extra incentive if they don't do it. So thank you for bringing that up.
Mark, feel free to react here too. But again, I also wanted to come to that second part of the question too. Again, we talked about the CMS changes, et cetera. But again, from your perspective, any other factors as to what's changed in today's environment that makes those incremental gains feel less like progress and really more like exposure for organizations?
Well, I do think about the RAD. You have to think about the RADV. And that does sort of change the temperature insofar as now, C-suite leadership at our provider group partners, at my plan, at other plans are now like, oh, it's not just table stakes. It's, CMS is actually coming for the wallet. So that then helps facilitate what action do you want to take? How do you drive this forward? So it's not, well, we should always get this on the back end after a year of work. It's the immediacy of now. This visit yielded this result. We have this true, accurate picture of the patient. We know what our score is. We know what our revenue will be as a result of that. I think it's also, margins are really tight now. There's a lot of difficulty in access to care where some of these clinics they don't have daylight for the number of members or patients that they're serving. So how are they finding that next percentage of capacity? And that is very difficult. So using tools under the guise of risk adjustment or under the scope of risk adjustment to say, here's a patient with a number of unaddressed chronic conditions. Maybe that's the next phone call to make versus this patient who has no chronic condition history. They need a checkup, but maybe they could wait a little longer. And I know that's a savage, finance guy type of view, but it's something that I think about a lot. I do think, Dr. Masudi, what you were saying before, I actually worked at Kaiser Permanente for a long time, and I agree with you. Yeah. The medical group there really had a very thoughtful handle on risk adjustment beyond it just being a financial lever, but that idea of a quality mechanism. This is a list of conditions to manage that have likely, yes, it will have revenue bearing, but they're built into the model because they are high impact, high yield, high need. So in considering that in the scope and building it to providers' workflows, you do see stronger engagement. You see more comprehensive and more immediacy of capture and engagement with the patients, which is fantastic. And then I also think about where I'm now with all of my FQHC partners. They don't think like that. They're not built like that. They have often with state Medicaid programs, a fixed per visit fee schedule. And with our value-based partnership on top of that, it's a little bit of a learning curve that a lot of my last 4-5 years here at CHBW has been more didactic. I do monthly webinars on the why of risk adjustment. Why does this matter to you, operations staff, clinical staff, and others? But again, going back to what you were saying before, it's if that information is upfront with the provider's providing the completeness of care for that patient, the math works itself out. If we know the totality of that patient, the revenue works itself out. And if we can do that up front, it's just all the better for the patient versus us mining something in the past.
Again, you've outlined a more proactive approach, come to the bottom level of just having conversations and education, as you've just outlined, which is so crucial to be able to enable a proactive approach, which is key. Dr. Masudi, I want to come back to what you've mentioned. I want to come back to what the alternative then looks like, right? We're trying to fix this. What does a clinical first approach to risk adjustment look like then in practice from where you are? And how does it fundamentally change when and how decisions are made?
Well, I think it starts with a culture and communication around the way you talk about risk adjustment. Because you don't have to talk about risk adjustment. If you're doing it right, you don't have to. You talk about how do we address all of the chronic problems this patient has. And even if you're not doing anything, we need evidence that you thought about it and decided to stay on the current path. And that is so much more palatable to physicians. They don't want to be thinking about money when they're taking care of their patients, and at least not money for the payer. We'll say that. Um, uh, and Yeah, so it starts with how you talk about it, and then it's really, I think it's a tech fix. We've got all these great tools with AI now, and we should be implementing them alongside the provider as like almost like a decision support tool, where it's evaluating the documentation, looking at the conditions addressed, and reminding the provider, hey, you didn't address COPD. That's okay, but just double checking, or you didn't document this quite right. And so doing all that then removes risk from audits. It removes all the costs of looking back at charts, annoying your providers. And then when the encounter's closed, it's done and you don't have to worry about it.
Mhm. Lisa, same question for you. What does this look like from your perspective? Again, that clinical first approach to risk adjustment. I'm assuming it's similar, especially when it comes to the culture piece. But again, what does that look like for you?
I think what needs to be, I think coding, risk adjustment, and clinical need to be more aligned and not, on parallel tracks.
Mm.
Being together is always, they're woven together at the encounter, and they create a better strength in the documentation. It's defendable, and you're taking care of everything at the point of care. I think the biggest thing is getting everything documented and taken care of at the point of care versus having to always go back and ask them, hey, is this really true or whatever. But no, I really think that clinical and coding need to be, interwoven.
How can they achieve that? From a strategy perspective, Lisa, what do they need to do to rethink that relationship? Are there ways that they can approach this to be able to create a more interwoven conversation and system?
I think giving more information about risk adjustment and the importance of it to everybody in the organization, because there's people in my organization, when I say risk adjustment, they have no clue. So making sure that they understand, and then really especially the clinical staff, of how we can really work together. This is something that I'm trying to tackle this year. We got a new platform, and trying to bring this all together. It's stuff that we've never had. So I think it's just that educational piece, and letting the right parties know how we can work together and be better.
Yeah, it comes back to what Mark was saying with the communication aspect of it and hosting sessions, right? Even if it's just those sessions to be able to say what's happening. John, same question for you. How should plants rethink that relationship between coding and care, sort of really as a result of what we've just touched on?
Yeah, so a couple of things and a couple of great points are raised. So one of the points that I'd just like to sort of elevate what Mark was talking about, there's a difference between, an important difference between interoperability and workflow. A lot of people talk about like, oh, we need more clinical data, and so let's go out and get more clinical data, which in and of itself, that's sort of what chart retrieval is, right? Where you're going and gathering more clinical data. But what I was referring to earlier is the timing of when you take action and when you incorporate that data into a workflow and how you influence what's happening with the patient and how you actually move numbers and affect change, that workflow is really ultimately where you want to get to. And so when we talk about what Lisa's talking about, when you move from that retrospective up towards where, Dr. Masudi is talking about, there is a responsibility when you go from that retrospective world into the, kind of that current where you have, your risk adjustment, quality, care management, kind of increasingly converging around this same clinical signal in this clinical first model. And part of that responsibility is you need to talk you can't turn clinicians into coders. You need to talk in the vernacular that the clinicians are talking in the vernacular that is patient first. So there's a responsibility that comes with that. And I know we're very steeped in, risk adjustment codes and HCCs and all that fun stuff. And that's important. But if you want to have those conversations and build the relationships with your provider community, you need to do that translating on the backside because, if you want to be in that conversation, I think it's important to understand what comes with a clinical first model. So, as I said, not turning clinicians into coders, and that means making sure that the clinical record accurately reflects the patient's condition while the care context is still active. So all of those things would be moving towards clinical first. Not easy, by the way. I'm not saying it is.
Dr. Masudi, would you like to be a coder?
Let me think. No.
I figured. I think I already knew the answer to that, but yeah,
Yeah.
that makes a lot of sense. Mark, just wanted to give you a chance to react here as well. Again, you've talked about that relationship piece and the cultural aspect of it, and when you think about some of the strategies, right? Again, how should plants rethink that relationship in and of itself to produce again better results?
Yeah, I honestly, it's clarity, it's honesty, and there's a didactic component. Like, let me tell you why I'm asking you this question. Let me tell you why I need to ask if you can do that one more question in a visit, which I know I say and immediately see providers cringe. But how do I help you so that the patient experience is I had one visit, I had a good comprehensive visit, my follow-up was taken care of. The patient perspective is, one visit back the cycle. We as a plan got like 6 different outcomes from that. The provider got a full assessment of the patient. And ideally, me as the plan partner, I want to say, hey, I can help you with like workflow ideas, or, do you need support for resources? Or can I show you some white papers of best practices? Or can I give you data and integrate that into the clinical workflow? So, Dr. Masudi, you're seeing a patient. You don't have to log into 17 different locations to find like what's Mark Dabney's, illness that I need to consider today beyond he hurt his knee. Like something to support that point of care, because if that point of care is as thoughtful as possible, everything else that we're talking about, the retrospective portion, diminishes in need because the immediacy of now is more complete.
And one of the things you have to give people to support them is time.
Yeah.
There's this push to always do more in a shorter period of time. If you want someone to really, truly address everyone's chronic conditions, for these sick patients, you might need a 40-minute visit instead of a 20-minute visit.
I
Yeah.
think that's an important fact to consider.
Mm.
The individuality of it as well, and the fact that it's not. It's I hate to use the word, but it's not cookie cutter. It's
Mm.
very important to be able to look at it from an individual perspective, which is so key. We've touched a little bit on the technology piece of this, and we certainly also touched on some of the mandates that are in place today, or that are becoming or are being put in place for 2026 and 2027, and certainly beyond as well. They have expanded access to clinical data. And I'd love to know how plans should use CCDs, ADT feeds, and really any other real-time sources to drive action at the point of care. And then also from your perspective, where are plans still leaving the most value on the table today when we're looking at all of this data that we have access to? Lisa, I'll start off with you.
Um, so we haven't, at least in the risk adjustment, started using the CCD, data. It's something that will be coming, but just making sure that the providers, have that data, it's in front of them. That way they can, document it there. If they know, hey, what if they had sickle cell trait? That's something that falls off the problem list. They don't remember. They know the patient has it, but they don't remember to code it. So if we're putting that data in front of them and making it easy, then they can address it during their encounter. But if they're just going into it blind and they're just saying, hey, what's going on, and document what the chief complaint, then we're not seeing the full picture. It's risk adjustment as far as documentation. I say it's like storytelling. You're telling the story of the member or the patient. So, make sure that it's complete, it's, coded to the highest specificity, but, we just really need how to figure out how to get these workflows to the providers in front of them so they can act on them.
Is that something that you're exploring right now? You mentioned that with the CCDs, but in general, you're looking at those workflows to be able to improve them and tell that story, as you said.
That is something that we're working on. Being a smaller regional plan, we haven't done a lot with provider education and things like that. So those are things that I'm starting. And
Mhm.
so I think having the CCDs in there for us, and, it's not necessarily, the provider, but also getting, Epic is one of the biggest EMRs that we work with, and they're very expensive to get the payer aspect. So, being able to, possibly have that bi-directional feed so they have that best practices, they know what's coming up when they pull up, the member in Epic or eClinicalWorks or whatever. There's a little, BPA that alerts them, hey, these measures and these conditions are still outstanding. And so they know, whether to bring it into the encounter, or if it's no longer, pertinent, then just, dismissing
Yeah.
it.
Yeah, absolutely. Mark, same question for you again. When we're looking at all of these data, all of this data, all of these real-time sources that are available that, that drive that potential action to the point of care, where are plans still leaving the most value on the table today when you're looking at that?
To me, it's understanding the ask of the providers, right? If we can use data to say, like, here's a patient that's been seen, they've had at least one visit, they've said yes to something somewhere, versus the patient that's at home that's less motivated to come in for care. Because our plan has Medicare, Medicaid, and like ACA populations. The ACA population is often, the young invincibles, the insurance for insurance sake. So finding out, well, who's that, population that needs care that hasn't, because they changed plans this year to us, and we have to find out who they are. So using clinical data feeds to understand, or using any of these input values to understand who's that population that wants care, just hasn't made that step, or has had some sort of care event like urgent care or something, but not that thoughtful, either specialist or PCP visit that we can bring them into and do that assessment, make sure that their quality of life is set in the right direction. But also we have a stronger picture of the cost of care, the totality of care, that then reflects their risk scores and either the revenue that we get or the premium transfer that we would make for ACA.
Yeah. John, are organizations doing this? Right? Are organizations looking at these various data feeds? Are they aware? Are they doing the right thing? But then again, same question for you. Where are you seeing plans just leaving the most value on the table in this conversation?
I think they are, and I think they are doing so. I think increasingly so. I think the plans that are doing it in a thoughtful, methodical way, and an example would be measuring their usage of CCDs and ADTs. Now, ADTs, of course, you can't use that for risk adjustment. It's not a certified visit with a doctor where the eyes are on the patient, similar to the way that the CCD is. So CCDs are being used for risk adjustment. They're authenticated, and those are saved, and they're pass a RADV, and so that gets you away from a lot of chart chase. So we do see that those are being measured in terms of how much does this reduce our retrospective chart chase retrieval, so they can measure the cost savings from an operational standpoint, and they can see if there's any impact in terms of the amount of codes that they're capturing, et cetera. But from an ADT perspective, it's very interesting. I saw a plan that was measuring how many of the actions that our care management team are taking on a day-to-day basis in terms of their outbound calls are based from information that came from an ADT, an admission discharge transfer, not from the claims themselves, or sometimes an absence of claims, right? We work from an absence of claims. If we don't see someone that there's claims there for prescriptions, we know that they're probably not taking their medication. But with ADTs, you have this very early signal. And so if we have care managers calling patients and making appointments with physicians, getting to what Mark's talking about, helping fill their appointment book with specialist visits and helping them close that gap, that's something that's very interesting, because the percentage of visits or actions that care managers are taking from those early signals, that indicates that there's going to be a lot better care happening.
Yeah. You all have touched on RADV certainly, and the audit changes that are coming. You all are aware of the tightening margins that healthcare is facing today, in general across the boards. What we've talked about today, in conjunction again with RADV and some of these changes that we're seeing, it's really an enterprise financial risk issue. It doesn't necessarily go to the heart of the operations piece, which is certainly part of it, but it's also a financial risk issue. Thinking about this from a financial perspective, what's the real dollar exposure for plans that delay this right now? Mark, can I start off with you?
Sure. I mean, it's fundamental and significant. Like the CMS RADV structure, there is the court case that struck down the right to extrapolate, but it's being appealed. And CMS is sort of going quiet on what they'll do or when they'll do it. If the way it's structured with the smaller samples, the impact is nominal. A CFO isn't going to worry about it. I've talked to my CFO about our exposure from prior audits. Mike, here's what I think it is. And it's a shrug and you move on. You already have that accrued. If extrapolation is allowed, it'll blow your margin. Like if you're aiming for a target, it just removes it because it is now taking a large portion. To me, the RADV, while it's looking at coding completeness and accuracy, it's a payment integrity audit. CMS has clearly said, like, you told me Mark Dabney had a 1.0 risk score. I need you to prove there's 1.0 of risk score for Mark. I'm less worried if it's the same HCCs you said. It just needs to total that. So there's this very fundamental need that, like, we need to be very thoughtful and immediate about our coding accuracy. Yes, this is going to require us to continue to do some level of retrospective or some continuing chart review. The ideal of moving it up front as close to real time as possible, whether in partnership with our provider partners and their coding groups, because I agree, y'all have gone to school for a million years to be a provider. You didn't go to school to be a coder, and I've had providers tell me that very directly. But having support teams who are experts at that to take what you've done and go that distance, that's one of the fundamental reasons that we're approaching with a lot of education. We do a lot of coding workshops. We'll sponsor like training and efforts and workflow design with our providers so that it's right up front and our back end numbers are more accurate to that, so that we don't get a surprise 6 or 7 years down the line by an audit that will, take 15, 20% of our revenue because a small handful of members had a small handful of errors.
Yeah. Lisa, I'm sure this is similar for you as well. But again, when you're thinking about the exposure of this, what is the real dollar exposure for plants that are delaying, that are not taking this out front?
Oh, it could be huge. I mean, just because, the more that we delay in making these changes, we risk losing, millions of dollars of revenue, and you multiply your RADV exposure as well. In this environment, I think waiting isn't neutral. It's a financial, punitive action, because, if you're not ensuring that everything is getting documented, not only hurting, financially, but also you're denying the member the type of care that they need. So I think having it all up front and instead of in the back, like I said earlier, that black and white, you know, um, I think it is going to improve, the revenue outlook if you're doing it, at point of care versus, at the end. You have, a chance to look at it. I almost wish that Medicare would do RADVs the same way as Marketplace. Every year you're not delayed, and you just move on. You're done. You don't have to worry about, well, there's some autos, later down the road, but that's what I think, is that we just need to be more proactive and not delay.
I would
John,
add,
oh yeah, go ahead.
yeah, I would add that there are some non-financial costs as well with provider abrasion, particularly.
Mhm.
And if you can create a system where once the chart is closed, the provider never has to look at it again unless they they need it for healthcare. Uh, it 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 helps a lot with provider abrasion.
Dr. Masudi, staying
Agreed.
with you then there, I'd love to get your perspective on this conversation too. Again, different perspective, right? Not necessarily the operational side of things and certainly the financial tie-in too, but I would love to get your perspective on this too, on what you're seeing just from where you're sitting. Is this a conversation that folks are having from a clinical perspective? Are they having those conversations? What does this look like for you?
I would say that the most important conversation around provider abrasion and the costs of doing things the way they are. One interesting thing I've noted that I don't think anyone has brought up today is that a lot of these large systems with some Medicare fee for service patients and some Medicare Advantage patients. So the risk adjustment is much more important in the Medicare Advantage patients. You're kind of asking the docs to do two different things. They should be performing value-based healthcare with anyone who's in a Medicare Advantage plan, and they should be maximizing revenue with all the other Medicare members. And one of the very important things for physicians, they don't want to treat people differently based on payer.
Mm.
And so you have to have singular senior care programs that treats everyone the same, high quality healthcare, as little as possible, and accurate documentation and capture of chronic diagnoses.
The outcomes matter. It trickles down to the patient at the end of the day, which is so
Yeah.
crucial, as you've just mentioned. John, I
I
just wanted
know.
to come back really quickly to the exposure part of this and the risk piece of this, right? When we're looking at these conversations that are certainly happening at the highest level of these organizations, right? How should that risk that we've touched on be framed at the board level, at the CFO level? How should organizations think about this?
Well, I mean, Mark brings it up. I mean, because of the extrapolation, you need to be thinking of this. It's no longer missed revenue retrospectively here. The issue is now is whether your operating model can withstand really continuous audit scrutiny at an enterprise scale. And when you say that sentence, that is very far from what Dr. Masudi said of, hey, just let me chart accurately and never see the chart ever again from the physician side. So these worlds are kind of diametrically opposed. But there's just so much risk. And that's why we saw a lot of exits from Medicare Advantage coming into this year. I think Cigna sold off their Medicare Advantage business to HCSC, and we saw a lot of exits from a lot of markets. And a lot of them pointed to the fact that, keeping up with all of these operational changes, the amount of risk and the amount of cost to put the operations in place to withstand all these changes, it's unsustainable.
Yeah. We have about 10 minutes left here. I think somebody mentioned that nobody ever wants to talk about risk adjustment. I'm certainly glad that we're talking about risk adjustment. Mark, I think you said that earlier. I do want to close this out sort of with a forward-looking perspective for everybody here. Mark, I'll start off with you. What are leading plans doing differently today that positions them ahead of all of this that we've touched on today? And again, for those that might not be there yet, what's that one thing that you want them to start today? What's that single most important first step?
To me, it's involving the providers in the discussion, right? It all boils down to that patient-provider interaction and what happens there. And so to what we've talked about before, do the providers know what they should be asking? Do they have enough information as that clinical decision support to have that informed discussion? Do they have enough time? And I'm stealing your comments, Dr. Masudi, but do they have enough time to do that? Do they have the information to do that? Are they incentivized to do that? But knowing that the why behind it in that partnership with them of this is what risk adjustment means to your workflow. A lot of the discussions that I have here internally aren't just well, we need this recapture rate. It is looking at the totality of a clinical workflow and all those points that risk adjustment impacts it. How do you engage your patients? How are you scheduling them? How are you doing the visit? How are you coding? How are you billing? How are you reconciling? The gamut, because risk adjustment isn't a thing. It is the sum total of all those events for a patient's totality of care. So understanding that and knowing that whatever I can do to help my provider be as thoughtful as possible and make sure they are aware of the why behind it, that's sort of the area. We can have all the tech that we want, but Dr. Masudi, if you didn't give a darn about risk adjustment or capture, and you're just this patient has a chief complaint, I'm going to treat his knee and send him on his way. If we didn't talk about and have that motivation, you would do exactly what you need to do for that visit, the 10 minutes that you have with them, and move on to the next 10-minute patient that you're forced to address. So to me, it's getting that partnership and that understanding with the provider is paramount. Everything else you can start folding into place from there.
You talked about communication earlier on in our conversation, and I think that that's really, really crucial and a great note to end that on. Lisa, same question for you again. What are those leading plants doing differently ahead of this shift? And again, what's that one thing you want organizations to start doing if they're still behind?
I think the leading plans are getting ahead by doing recognizing this shift as an enterprise-wide shift, not just a risk adjustment or quality or care management. It's the enterprise, and if the whole thing doesn't shift, then you're going to be in trouble. The other thing that starting small, test out the different workflows like Mark has been talking about, because also without the provider engagement, then you're not going to move that needle. So it's got to be not only just the plan side, but getting the providers engaged. If they don't know what the member has, or if they're not getting their members in, that's a problem that we've seen, is that members just aren't being seen. And so having to do that outreach to make sure that you're getting them in, because if they're not seen, then they're not, hopefully not doing you any cost, but is that really the way it should be? So I think just getting the data to the providers, and also to having a strong risk adjustment team internally that can pinpoint certain conditions, or do those outreaches then I think it'll just be, a stronger um, outcome.
Dr. Masudi, for you, the question would rather be, what would you like to see?
Yeah.
Or what
Oh,
would, yeah, same question for you again.
yeah.
What do you want to see? What's that first thing you want organizations to do right now?
Well, I think Cleveland Clinic may be onto something. They have decided that when everyone is zigging by getting out of Medicare Advantage, they're going to zag. And I think what it looks like is provider-sponsored MA in a system that treats all seniors the same with high quality health care. And they accept the risk of taking care of the patients, and there was an article in the New York Times today about a pro golfer who was in the Saudi tour and now is coming back to the PGA, and he's starting at the very bottom. He's used to always being in these big tournaments, and now he needs to like find his way back. And he had a very interesting quotation. He said, "The answer to everything is to play better." And that's the way it is in healthcare. The answer to everything is higher quality healthcare. And if you do that, everything else works out. And I'm interested to see how Cleveland Clinic is going to handle that. How are they going to provide better, higher quality healthcare and make money doing it?
John, same question for you. Again, when you're looking at this down the line from the organizations that you're working with, that what you've seen work, right? What are they doing to position themselves ahead of this? But then also, what's that one thing you want them to start doing right now if they are still behind?
Continue if they haven't already. I would say continue more of the same, and so it's reducing the dependence on retrospective retrieval, moving towards encounter aligned workflows. And so I'm not going to steal from the great ideas that were just shared, but most importantly, you're asking, how do we improve? You don't ask, how do we improve chart chase? You do ask, where should this have been identified earlier? Where's the earliest signal, and how do we maximize that? So it's bringing the groups together that Lisa was mentioning, risk, quality, care management, bringing those groups together and determining where is the earliest possible signal, when can we get that data? How can we change our workflow around that to optimize that situation for our own internal operation? And what does that now look like with our communication with our providers and that partnership? How does that change? And hopefully that's changing for the better in a partnership manner. Hopefully they're seeing, a better collaboration and better patient care because there are gaps in care there, in terms of, like we were talking about, their appointment book is getting filled, and they're seeing patients come to their appointments armed with questions and information. They have better relationships with their care managers who are essentially serving more as the quarterback of care for those complex patients who have comorbidities and have to get to many specialists, and often are the ones who can get lost lost in the cracks because their care is so complex. So I'd love to see that.
I want to thank you all for taking some time and being here today. I think we all along played on PGA Tour level, I like to think, in our conversation throughout. I want to thank you all for taking some time. I want to thank InterSystems for bringing us together for this wonderful conversation, for sponsoring today's webinar. Again, to our audience, thank you so much for joining us and listening in. And I hope you have a great rest of your day. Thanks so much for being here.
Thank
Thank you,
you
Lucas.
so
Thank
much.
you, everyone.